Hi, this is Dr. Artie Kavanaugh, and I'm happy to join you here on Room Now. The topic of this discussion is difficult to treat rheumatoid arthritis. An interesting topic, and it's hard not to harken back to the Judge Potter Stewart said in 1964 in the case of Jacobus versus Ohio. He said, I may not be able to define it, but I know it when I see it. Of course, he was talking about movie pornography, but I think that's the way a lot of rheumatologists feel about difficult to treat rheumatoid arthritis. I don't know how to define it, and people are starting to think about defining it, but I certainly know it when I see it, and I think that's the way most of us feel. What is difficult to treat rheumatoid arthritis? Well, I think we could flip that around and say, what is easy to treat rheumatoid arthritis? Fred Wolf said that about fibromyalgia years ago. The ACR asked him to give a presentation on difficult to treat fibromyalgia, and he said, I don't know how to treat easy to treat fibromyalgia. I think for our rheumatoids, we're blessed with such a large number of therapeutic options these days. Back in the day, we had gold injections and sulfasalazine and that new drug methotrexate, and that was it. So a lot of our patients were difficult to treat. We didn't have many options. Now we have lots of options, but we still have patients where we're not achieving the goals. And of course, the more therapies that we've had, the higher the goals of therapy have become. Indeed, we want remission for all of our patients. How many patients do achieve that? How many easy to treat RA patients? I don't think it's that many. I think maybe 25% of patients. And easy to treat to me means you get on their first drug, rarely hydroxychloroquine, more often methotrexate, sometimes methotrexate and a TNF inhibitor, sometimes other mechanisms, and they do great. They don't have synovitis. They come and see you, and their checkups are quite easy. They're tolerating the medicine. But that means the rest of the patients are difficult to treat by definition. What makes them difficult to treat? Well, I think many of us would agree from an immunologic standpoint, there are patients who have persistent synovitis, and we've given them good tries of many medications, and they still have persistent, abundant synovitis. Those people, seropositive in general, often with extra-articular manifestations, have been on therapy after therapy. There's no particular number to me that says it's difficult to treat rheumatoid arthritis, but we know that there are those patients out there. But I think that's a smaller subset. The difficult to treat is more of a complex construct to me than just that immune construct. I think it has to do with a lot more of the doctor characteristics and the patient characteristics. Certainly, we work with our patients. We don't prescribe drugs to them. We give them choices, and we work with them to pick the choices. And we all know that there are patients who have difficulties with medications. I think my heart sinks if I read a chart for a patient I've not seen before, and they're allergic to 20 different medications. I know that the chances I'm going to find a medication that they've not been on that's going to work are going to be relatively small. And I've also learned over the years for our younger viewers, back when I was young and knew everything, I would often engage the patients and say, well, this shouldn't make your teeth itch. I don't know that I've never seen that before. It doesn't matter. If they think it makes their teeth itch, they're not going to take it. We're also frustrated, I think, difficult to treat when we see charts where patients have been on one medicine after another, and perhaps only 1 or 2 months of a trial. In that case, I'm not sure that we would define that as a failure. Still, the patient is difficult to treat. A big issue is the compliance with medications. And when I have younger trainees, sometimes they'll wonder what's going on. Why do I ask the patient 2 and 3 times about the medicines that they're taking and what day they're taking it and what does it look like? Because there's no medicine that's going to fail like a medicine that the person is not taking. So compliance or having the patient actively participate in the choices is super important. So to me, this is why difficult to treat rheumatoid arthritis is such a tough issue, because it involves potential immune contributions, doctor characteristics, and patient characteristics. We have lots of choices, but we still have patients that we need to do better with. Thank you.